Hello, everyone. I'm Vincenzo Berghella. Thanks for coming again to another live event from AJOGMFM. I have an amazing panel today to discuss timing of induction versus expectant management, I guess, for term pre-labor rupture membrane. I'm going to ask each panelist to introduce themselves like we usually do at AJOGMFM. Federica, why don't you start?
Hi, I'm Federica. I'm from Italy, born, raised, and trained in Italy, and now I moved to Philadelphia, US, since January 2020.
John?
Why, Federica? Why
Because
did you
my
do that?
husband lives in Philadelphia.
Okay, there's got to be a reason. So I'm John Barrett. I wish I was born and lived in Italy. I live in Toronto, which is a town near Hamilton, Ontario, Canada, where I'm the chairman of the Department of Obstetrics and Gynecology.
In here.
Hi, thank you, Vincenzo, for organizing this. Nirmal Ahmed from Sunnybrook in Toronto as well. I'm a staff MFM, a scientist, and the head of research at my institution.
Thank you all for coming. So like I say today, this AJOGMFM live stream being broadcasted again live on Facebook, on Twitter, on YouTube, on LinkedIn. It's on timing of induction in term PROM, an issue that is actually fairly common. And we love here at the Pink Journal to address common obstetrical issue that we deal with every day. So as we call it, pre-labor term rupture membrane, PROM term, of course, in up to 8% of term pregnancies, which as there are 145 million births in the world, over 10 million pregnant patients end up having PROM term. So it's a very, very common issue, which also means that every hour, so during this quick broadcast, more than 100 term patients will experience these situations. They're home, the membranes rupture spontaneously, they have a big gush of fluid. What should they do at that point? And I've been interested in this issue as a clinician for a long, long time, as I know Federica, Nir, and John have. And I just wanted to show you this slide from 1970. AJOGMFM is a sister journal to AJOG, the premier journal in our field. And in 1970, it's not before some of us were born, but it's a long, long time ago. It's 53 years ago. Amazing. This is a great study from Dr. Gunn, Dan Mitchell, a very famous GYN, OB, and Dr. Morton. And look, they 12 hours, 24 hours on the x-axis, latent period. They actually had perinatal mortality on the y-axis because back then, again, 53 years ago, babies actually died of this. And it's unbelievable to me how cruelly, even at 12 hours or 24 hours, babies actually died of term pre-labor. Back then it was called premature, and sometimes still is called premature rupture membrane at term. And I was always amazed that, I would take call as a resident, as a fellow, and the attending would say, oh, you rupture membrane, it's 2 a.m., why don't you stay home? Relax, come when it's convenient, no rush, pack your bag and whatever. If you're far, take your kids to daycare. If you have older kids, no rush on this at all. And this is a graph that I was looking at for a long time. And it makes sense that time is not on our hand. The vagina, as we know, is plentiful with bacteria. And if the cervix is open, as is often is with rupture membrane, or even if the membranes are ruptured, those bacteria ascend, as we know, very much, and they can infect the membranes, the amniotic fluid, and eventually the baby, and called neonatal sepsis, and again, in the past, even death. So it makes sense that if you give it enough time, those vaginal flora ascend to the uterus. And I'm still amazed, and I guess the main point, to give our message away at the beginning, I'm still amazed that ACOG, as wonderful as we are, because we all write and help with ACOG, states that for pre-labor rupture membrane at term, as you can see here in the slides, at 37 weeks or more, is spontaneous labor, and I'm reading, does not occur near time of presentation in those who do not have contractions in labor, which is actually, as Nir, I think, will show later on, the majority of women. labor induction should be recommended, although the choice of expectant management for a short period may be appropriately offered, which I think with the data we have today, thanks to Federica, Nir, and John, it's not really that safe. But again, I think that it's still a debate out there, and even from AJOG. So with that quick 5-minute or less background, I'm going to give it to Dr. Bellucci.
So when we think about PROM at term, we usually think about a patient. We are in labor and delivery. We have this patient, PROM at term. It's 3 a.m. Should I suggest induction of labor right now? Should I wait and see? Usually, if we think about wait and see, if because it's common sense to think that we are giving her a chance for a spontaneous vaginal delivery. But is this really true? So this is where my interest is in studying about the timing of induction of term PROM started, as it happens for the vast majority of our clinical research. So I started with this retrospective cohort study that was published in the AJOGMFM, the Pink Journal, in October 2020. And in this retrospective cohort study, we decided to examine all the term PROM patients in our hospital in Bologna, Italy. And we divided them in 2 groups. Those who were induced within the first 6 hours since PROM, and the other group is comprises patients induced after 6 hours. And so we found that the induction of labor within 6 hours from PROM was associated with less use of antibiotics, 36% versus 80%, less non-reassuring cardiotachograms, strip, so 6% versus 19%, and actually same rate of vaginal delivery. So actually the expectant management was not associated, according to our data, with an increased chance of vaginal delivery. Then we decided to do a systematic review and meta-analysis on induction within or after 12 hours, that I believe is a most used cutoff, in term PROM, so patient after 36 weeks of gestation. We published this a systematic review and meta-analysis in June 2021 in the AJOGMFM. So overall, we collected 9 randomized control trials we included in this meta-analysis. And they were comparing patients who were induced within the first 12 hours from PROM and with expectant management. Our primary outcome was chorioamnionitis. Regarding the patient's characteristics, the average gestational age of randomization was 39 weeks. They were singletons, mostly nulliparous, 63%, and we found a similar incidence of smoking between the 2 groups. BMI, unfortunately, was not reported, and sometimes we found the bishop reported. Usually it was less than 6. And we found a slight increased incidence of GBS positive in the induction group. The patients involved in these randomized control trials came from all over the world. So we found 1 trial from South Africa, 1 from Israel, from Turkey, from Denmark. 2 out of these 9 RTCTs were from Sweden, 2 from Canada, and 1 from the US, from California. So according to these data, and not surprisingly, induction of labor within 12 hours was associated with a lower latency between PROM and delivery. So induction of labor within 12 weeks was almost 13 hours quicker. Regarding the labor characteristics, again, not surprisingly, induction of labor was associated with less spontaneous onset of labor and more induction, of course, 92%. And expectant management was associated, yes, with more spontaneous onset of labor, because 76% of these patients underwent spontaneous onset of labor, and some of them, 24%, were induced, usually after 24 hours, but they had significantly more cervical examination during labor, more than 8. But the fact that they went spontaneously on labor themselves, does it mean that they had a vaginal delivery? Well, actually, no. In fact, if we see this data on the mode of delivery, the expectant management was not associated with more chance of spontaneous vaginal delivery. The cesarean deliveries were 9.8 versus 10.1%, so very similar in these two groups. So no increased chance of spontaneous vaginal delivery, neither of operative vaginal delivery, if we choose the wait and see, the expectant management. So as I said before, our primary outcome was the incidence of chorioamnionitis. And as you can see here, the induction within 12 hours of term PROM was associated with a decreased risk of chorioamnionitis. And we have 5.3% versus 9.9%, which is significant. And the risk was significantly lower with the early induction. The number needed to treat was 21.7. So this means that for every almost 22 patients that I decided to induce within 12 hours, I am preventing one chorioamnionitis, which is really important. And also regarding endometritis, we found a benefit in early induction because endometritis was significantly more frequent in patients with expectant management. And we didn't find any difference between these two groups in the rate of epidural, neuraxial analgesia, IV antibiotics, episiotomy, and length of hospital stay. Of course, we care about the maternal outcome, the mode of delivery, but it's very important to consider the perinatal outcome as well. So we didn't find any difference between these two groups regarding the arterial pH less than 7.1 or a low Apgar score. But importantly, we found that neonatal sepsis and NICU admissions were significantly lower when the patient were induced within 12 hours. So early induction within 12 hours decreases the risk of neonatal sepsis and NICU. And we know that neonatal sepsis is a great risk factor for neonatal morbidity. So if you remember, I started with this retrospective study that we did in Italy, and our cutoff was 6 hours. So we did a sub-analysis in this meta-analysis with using a 6 hours cutoff. And we found that induction of labor within 6 hours from PROM was associated with a significant 46% decrease in endometritis, a significant 67% decrease in neonatal sepsis, again, and another significant 44% decrease in an ICU admission, while we wouldn't able to find with this cutoff a significant decrease in chorioamnionitis, but still there were a trend, so a not significant 39% decrease in chorioamnionitis.
Federica, I'm gonna stop you on that slide. I think this is one of the most important slides, because people talk about, if you think about 12 hours, maybe you do have time to, relax and stuff, but you have significant results, even for neonatal sepsis and NICU, for neonatal outcomes, which people care about the most. And 6 hours is pretty quick, from the time you realize you rupture membrane.
Yeah.
That really means that you need to get to the hospital right away.
It basically means that when you see the patient in the ED, you admit the patient and you start induction right away. And yes, I do believe that a significant decrease in endometritis, neonatal sepsis, and ICU admission without any increase chance of vaginal delivery, it's enough to make this decision. So in conclusion, what can we recommend to this patient PROM, a term that we see every day, at least once or twice in our clinical practice, we can say that induction of labor within 12 hours, or probably within 6, in patients with singleton cephalic gestation with PROM is associated with shorter time between PROM and delivery, less chance of delivery in the next day within 24 hours, less cervical examinations, 38% less chorioamnionitis, also a 40% less endometritis, a decrease of 54% in neonatal sepsis, and an ICU admission. And if we decided to wait, we are not giving her a chance of more vaginal delivery.
Thank you, Federica. That was great and pretty straightforward. So we'll do the second and last official presentation with Nir. So you can load your things, Nir, and see how his data and how his study came about. You're muted, Nir.
Sorry, I was muted.
Yeah, now you're unmuted. Now you're good. There you go.
Okay, so again, thank you very much, Vincenzo, and thank you, Federica, for a beautiful presentation. I'm going to present our study on optimal timing of labor induction after term PROM, and which was based on a secondary analysis of the landmark term PROM study. I would just mention this study was really initiated a few years ago when Vincenzo reached out to John and myself with this great idea. And it took some time, but this study eventually was published earlier this month. So thank you again for coming up with this brilliant idea for this study.
Well, you did all the work, so you deserve it.
As we mentioned earlier, term PROM is a pretty common condition, and we saw the evidence that both neonatal and maternal infectious mobility increase progressively with time following PROM. And because of that, generally it is accepted that induction of labor is the best course of action in these cases. However, as Federica mentioned, the ideal timing of labor or how early is early induction remains still unclear. And most guidelines recommend induction within the first 24 hours. However, as Federica showed very nicely, there is evidence that induction of labor even earlier, within the first 12 hours, or perhaps even the first 6 hours, may be associated with an even better outcome. And the questions that we tried to address in this specific study was whether we can identify the optimal time of labor with greater precision within this 12 hours framework. And we all know that the best source of evidence for induction of labor in cases of term PROM is this term PROM study, which was published by Mary Hanna in the New England Journal in 1996. This was a large multi-center study where women with term PROM were randomized into one of 4 arms. They had 2 induction arms with either oxytocin or prostaglandins, which are shown here by the red boxes, and 2 expectant management arms where women were managed expectantly for up to 4 days, following which they were induced with either oxytocin or prostaglandins. And overall, there were no differences between the 4 groups when it came to the primary outcome, which was neonatal infection, even though as the induction oxytocin group here on the left was associated with some reduction in maternal infectious mobility. However, when we come to interpret this study, we have to keep in mind that even in the 2 induction arms, which you can see here in red, the median time from PROM to induction was about 8 hours and up to 14 hours in terms of the interquartile range, which means that it wasn't really immediate induction. And therefore, the question is whether an earlier induction or immediate induction can actually be associated with greater improvement in maternal and neonatal outcomes. And we thought that this study would be the best source of evidence to address this question, because this study is unique in the sense that it had very detailed information about the timing of labor induction or the timing of spontaneous onset of labor from the time of PROM, as well as because it's large sample size. So our objective was really to use the data from the term PROM study in order to identify the optimal timing of labor induction in cases of term PROM. And we thought to do that by comparing the maternal and neonatal outcomes in cases of labor induction versus expectant management at any given 1 hour interval following PROM. And for the purpose of the current study, we considered all the study population as one large cohort, irrespective of the original study group allocation. Our exposure was the time from PROM, which we consider as a continuous variable in 1 hour intervals. And that's probably the main strength of this study, because unlike most previous studies used or considered the time from PROM to induction as a binary variable, such as induction before or after 12 hours or before or after 24 hours. And what we did was, at any given 1 hour interval following PROM, we compared the outcomes of patients who underwent induction of labor or started induction of labor within this 1 hour time 1 hour time frame versus those who were managed expectantly during this 1 hour time frame. And you can see here the outcomes. The primary neonatal outcome was a composite of either neonatal infection or NICU admission, and the maternal outcomes were maternal infection and cesarean delivery. Here we can see the the study cohort, and as I mentioned earlier, we considered all 4 study groups as one single cohort. We identified overall 4,742 women who were eligible for the current study. 2,622 underwent labor induction, and 2,120 were managed expectantly. And here in this graph, we compared the primary outcome, which was a neonatal composite outcome, between women who underwent induction of labor, which are shown by the red line, versus those who underwent expected management, which are shown by the blue line, at any given 1 hour interval following PROM, which you can see here along the x-axis. And the first thing that comes to, which is obvious, is that the rate of neonatal outcome really increased continuously with time from PROM in both groups. And we can also see that the rate of the primary outcome was significantly lower in women who underwent induction of labor versus expected management anytime within the first 20 hours from PROM. And findings were the same when you look at the specific outcome of NICU admission. Women who underwent, or the rate of NICU admission was lower among patients who underwent induction of labor versus expected management anytime within the first 15 hours following PROM. And when looking at maternal infection, findings were very much the same. The risk of maternal infection increased progressively over time in both groups, and the risk was significantly lower among patients who underwent induction of labor versus expected management anytime within the first 15 hours following PROM. In contrast, and very much similar to what Federica showed, the rate of cesarean section was pretty stable throughout the first 36 hours and was overall similar between the induction and expected management groups, so that the management did not affect the rate of cesarean delivery. 2 more outcomes we looked at were the time from PROM to delivery and the total maternal hospital stay. And when looking at the time from PROM to delivery on the left, you can appreciate that the time was significantly shorter for patients who underwent induction of labor versus expected management anytime within the first 36 hours. And very much the same way, the total maternal hospital stay was significantly shorter among patients who underwent induction of labor versus expected management within the first 24 hours. And finally, one more thing we looked at was to calculate the likelihood of spontaneous onset of labor over time among patients who were managed expectantly. And as you can see here, it's probably only about 64% of patients who were managed expectantly experienced spontaneous onset of labor within the first 24 hours. And this is a figure that may be relevant for the purpose of patient counseling, as well as from the perspective of resource utilization. So just to summarize, our findings suggest that immediate labor induction appears to be the optimal management strategy in cases of term PROM because it minimizes both neonatal and maternal morbidity, time to delivery, total maternal hospital stay without affecting the risk of cesarean delivery, and it may be associated with reduced costs because it decreases NICU admission and maternal hospital stay. In cases where immediate induction is not feasible, then we suggest that labor induction remains a preferred option if performed within the first 15 to 20 hours. Thank you very much.
Thanks, Nir. That was wonderful. Maybe the first thing we can do, we can give it to John, and maybe you can give some overall comment on this data. What do you think?
Yeah, thanks, Vincenzo. Federica, Nir, thank you for presenting the data. So this was, you're right, Nir, Vincenzo, you, I think, made a phone call or sent an email and said, hey, what about this? And it took me back to one of the first trials that I was ever involved with my mentor, Mary Hannah. I was the site investigator, junior, just starting off trials when this trial was done. And it basically is a soft spot because I think it was one of the trials that made me interested in trials. And it always worried me that the analysis was sort of, not linear, because we know that time is linear. And when people present, they present it at a distinct path along the way. And so to have a non-linear cutoff more than 12 it always concerned me. And so I think this is, for that reason, a very important study. The other thing is, in obstetrics, we tend to, the inertia of practice is very difficult to overcome. And so we carry on practicing the way we practice, believing it's right. And then every now and then we get data which should sit up and make us think. And I term it practice-changing data. They don't come along very often. Sometimes they're in the form of a single randomized controlled trial. Sometimes they're in the form of a meta-analysis, and sometimes it takes a lot to change the way we practice. We know that from much of our data. And I think, to be honest, when Vincenzo, you came up with that idea and he said to me, hey, John, do you still have the data? And I said, I think we do somewhere. And we dug it out and managed to get the data sharing agreements. And then the statistical analysis was another method. But at the end of the day, when we put these two papers together, Federica, your beautiful meta-analysis and this landmark trial analyzed in this way, which I think is the right way to do it, I really believe this should be practice changing. It should be something that makes all of us sit up and say, why are we doing things the way we do? Because it's not what we do now. We practice linearly. We practice in a set cutoff, and we give patients choice, which we always do. But we have to give patients choice with the right information. And I think this is now as close as we're ever going to get to the right information about the risks and benefits of non-induction. So I really think these two papers together are practice changing. And if we're doing our job correctly, it will be spread out to our professional organizations, because I think the time is correct to rewrite the best evidence we have in this topic. So congratulations to the both of you. As you say, Vincenzo, they did all the work. And I think it's up to us now as we sort of maybe the more senior people to reflect what this means back to our professional organizations to say we should change practice based on this paper, on these two papers. So thank you for giving us the opportunity to do this together. And yeah, we can have some discussion.
So I guess ACOG, Society of Obstetrics and Gynecology of Canada, RCOG, FIGO, SMFM. I hope you're listening and listen to Professor Barrett. I think it's really important. It was kind of been a dream of mine to look at data. Like I said, I looked at that graph from 1970. Some of this data we knew. We always knew that longer labors last, especially with rupture. Remember, the more in trouble you get. So it makes sense. Neo, can I ask you to put up your slides again? I wanted to emphasize one thing, because should we go now from 24 hours, which a lot of guidelines talk about, to 12 or 6, like Federica said, or should we go to immediate, kind of like near, like you said? And if you can share your desktop again, I wanted to show those slides where you look at 0 to 4 hours, because even at 0 to 4 hours, which is right away, you can and feel free, you can go back to the results. Yeah, right there. 0 to 4 hours. This is the neonatal outcomes. There is a relative risk of 0.81. A decrease of 29%, right at the beginning. And I think you can walk through the next few slides and emphasize 0 to 4 hours. It's all the same. It's where the best data is. Even 0, like maternal infection, at 1, 2, 3, the first couple of hours come in right away. If you want to have a 2% risk of maternal infection versus 6, 8, 10 plus percent. It's really telling, and I'm always amazed at, maybe I'll give it back to John. How difficult was to do the HANA trial? It's thousands of patients, and we need to abide to what the data shows from those humongous efforts, and the data, I think it's as clear as a sunny day.
You're right, Vincenzo. That's why these kind of things, these trials, they're probably not going to be repeated. They take a lot of money, they take a lot of time, and when they conducted properly like this, I don't think that this is. I think this is the best evidence we are going to get on this data, and it seems pretty clear. I think it's really fascinating. You think. The way we were brought up in the beginning is, non-intervention. The minute you intervene, either for induction or especially with induction, you're going to increase the cesarean section rate. And it took our career to get the ARRIVE trial when we realized that we were confounded by all the confounding things which make it not true. That induction does not necessarily translate into an increased cesarean section rate. And I remember
if you look at the slide that Federica showed.
Yeah.
And again, I don't want to be, we talked about before coming on, everybody's biases and stuff. But I bet if there are a couple of thousands of, 1,000 or 2,000 more patients in this meta-analysis, this, 1.08 upper limit becomes significant, and maybe there's even, like you said, ARRIVE trials and other trials that induction, it's probably better. I mean, we know that it's not worse. But it's probably even better.
It's probably, if you did big enough trial, it'd be better. Exactly. And so, that was the mantra upon which we always worked, is that if you intervene, you're going to have an increased operative delivery. And we know now that it's not true. It's not true, and it probably isn't true here. It's equal. And so that was always I remember doing, I'm sure there's still trials, people talking about ripening the cervix, because you don't want to induce on an unripe cervix. And at the back of my mind, there's this, every time I see somebody coming in with PROM and she's got an unripe cervix, which is long and closed, and we start inducing, I say to myself, oh, well, she's going to have a cesarean section, and she probably does. But that doesn't mean it was the induction that caused it. She would have had it anyway. And it takes that logical leap to say, you might do the trial we might need to do is whether you should try the induction at all, rather than in other words, do you go straight to cesarean? That will be a big jump for many people. But what I'm saying is, it's not the intervention, it's the patient that's determining the path. And it takes an analysis like this and the meta-analysis to show. And now all we can do in this world really is provide the best evidence to patients. And yes, there are still patients that are not going to want induction because they just don't want, they want it to, and Neo, you said it's only 64% will go into labor, and I can just hear my other colleague, it is 64%. And there are people that are going to say, well, I want to be in that 64%, even though it might mean I have I find it difficult that somebody would say, I'd rather be in that 64%, even though I know it might increase my chance of baby getting an ICU. I mean, I know there will be people who make that choice, because I've met people who make that choice, but I find that difficult, and at least we should be clear about it. I mean, what do you think?
Yeah. So, first of all, it's important to understand that because, and this is something we discussed in the paper, and this is a common mistake because of some I guess typing error in the original version of the term PROM study in the New England. The proportion of patients that experience spontaneous birth within the first 24 hours was cited as 98%, and it was a wrong number. It was because it was cited from the wrong table, and it's on actually one of the residents in Israel actually picked up this mistake in the AJOG guidelines, and it took few communications with the AJOG until AJOG actually updated their guidelines that was affected by this very common mistake in the original version of the New England paper in 1996. So first of all, people need to understand that it's only 64. It's not. People often tend to cite a higher a proportion. And the second issue is that most places would not wait 24 hours. I mean, in our setting, for example, we wait 12 hours. And I can tell you, if you go back to the same graph, 12 hours, only about 15-20% of patients would experience spontaneous onset of labor. So relatively very small proportion, which means that about 80% of women would eventually need induction anyway at a later point, where the outcomes might be worse. So I think that just having showing this kind of graph to patients would be very helpful for them to actually understand what the natural history is. The second issue is really, what do we do with this information? And there are two main reasons why women would not be induced as soon as they present with PROM. The first one is system limitations, and that's something objective that's going to be hard to address. It takes a nurse. You have to start oxytocin. It takes a room, and if the patient shows up 12 hours later, if she's within this 20% who shows up in active labor and progresses faster, doesn't need oxytocin, it definitely takes less resource from the system. So that's something that is going to be, this is real life limitations, right? And if you have a very busy ward that doesn't have the capacity to immediately admit all patients for inductions, that's one thing. But as you mentioned, John, many patients actually prefer not to undergo induction, even when it's possible from their resource perspective, just because they conceptualize induction as a negative intervention. And I think that just having this data out there and showing them what is their actual likelihood of experiencing spontaneous onset of labor within this 12 hours time frame, and how the risk of both risk for the mother and the baby increase over time, I think that at least some of the patients may be convinced and would be more likely to agree to undergo immediate induction. So I think the first really step is really to have the data, share the data, make sure that the policymakers, make sure that patients are aware of that, and take it from there.
Thanks, Nir. Federica, any comments from you?
Yeah, I was thinking while you were talking. So why do you think the patients prefers not to be induced? It's because of our counseling. It's just because of that. It's because of what we say to them. So because I don't think they just, if you say there is a decreased chance of having your baby in an ICU, if there is a decreased chance of you having a severe infection, so I think that it would be difficult that the patient doesn't agree to the early induction. And I think that the only reason you can now use to, if you don't want to induce the patient, is because you are very busy because of the system. But probably it's sad, but I believe that many people will say, because you may enter spontaneously into labor and you may have a high chance of vaginal delivery. Because I think it's sad, but sometimes we just don't believe the data, and I think we should trust the data, at least for these patients that were randomized 20 years ago in all these trials, and we just put together the data, and I think we should do it at least for them.
Yeah, it's interesting you say that. You see, so and I keep on coming back to the similarities between this new way of looking at PROM and the ARRIVE trial. So whatever we think about, the effect of induction at beyond 39 weeks on the cesarean section rate, I can still understand somebody not choosing that, even though it might result in a lower cesarean section rate, because in that group of patients who you choose to induce, there is an induction process. They spend a lot more time on the labor floor. It is a medical process. So I can understand somebody choosing not to be induced at 39 weeks, even though the cesarean section rate is lower. I can understand it because it changes the birth process.
I cannot. I'm just going to put my hand.
Okay. I can understand, because for some people, the cesarean section is not the end of the world. It's the birth experience. Okay, so I can get that. I can't get this one. I try to wrap my head around it, because this one, not only is your cesarean section rate not different, your time on labor floor is less different. The majority of patients will still have to get induced anyway. So this one, the whole birth experience, not just the outcome, but the whole birth experience is ultimately likely to be better if you get induced. Unlike in the ARRIVE trial, where, okay, cesarean sections increased by a percentage, but the birth experience is different. I get it. This birth experience is going to be better if you induce. So even from those people whose primacy is the birth experience, not the outcome, this one is better. And it's not just cesarean section rate we're talking about, just cesarean. We're talking about a baby in the NICU. So I find it very difficult that anybody would make a different choice now. And I would love to have what do we do now? Do we have a couple of focus groups on people and see what people think about this? Maybe we're going to make history of insurance. Maybe we get all the colleges to have one statement based on the same. Wouldn't that be a novel thing? We have one statement from American College, from SOGC, from FIGO, from NICE, from Ranscott.
What a dream.
All on one paper. I think this is the one that can do it, because it's so clear. Federica, your meta-analysis is clear. This is a landmark trial which will never be repeated. This is clear. I think we have a chance if we can get everyone together in the same time zone. This is one paper, one guideline. It doesn't have to be a new guideline. It's just a statement, which is less than a guideline. I think we could maybe try that. I don't know.
I would say, John, I would just add that I totally agree with Federica. It goes back to the way the patients are being counseled. At the moment, the message is that, either waiting for 12 hours or induction is probably associated with the same. There is no harm in waiting for 12 hours. I think that's the message that patients get. And I think once this message is presented differently, this might definitely convince at least some of the patients to undergo immediate induction. In terms of the system, I think that one interesting next step might be to actually take this data and just do some sort of economic analysis and just kind of provide some sort of estimate in terms of, given that we know the large number of patients with PROM. If you add on top of that the difference in the NICU admission and the total difference in total maternal hospital stay, you can actually come, with the quantifies the amount of savings you can actually come up with by doing immediate induction versus the current practice, which is waiting for 12 hours. And I think that's something that might be convincing to some of the policymakers, to hospitals, to the Ministry of Health to actually adopt this kind of recommendation.
So I have a couple of comments on this as well. So I think the next time people are listening, and there are hundreds and sometimes thousands, they just say, I want to wait 6 hours, you should say, Dr. Belusi say it's dangerous. If they say they want to wait 4 hours or 0 to 4 hours, Dr. Melamed says it's dangerous, and they shouldn't wait at all. And immediate was actually the title that AJOG ended up, giving to your wonderful study. And going back to arrive, arrive, and I know it raises a lot of discussions and stuff, but it is induction, no induction. So I understand why John brought it there. I wasn't going to bring it up. Satisfaction was actually better in the induction group. Pain was better in the induction group. The only thing that was a little longer was the time in labor. But overall cost effectiveness, great to bring it up near, was better with induction labor. There were less visits, less postpartum readmission. As you know, there was less hypertensive disorders. Really, the neonates did better. It's to me, that's also black and white. Again, people, I agree with John, are always going to say no, and that's fine. People smoke and people don't wear helmets, and I think that's fine. Really, we're not going to jail everybody. We're not here to do that. But I think the people that don't wear helmets, they know their risk, even minuscule. People that smoke, I think they all really very much know their risk. And I think maybe as of this, you, John, you're almost, saying we should write an editorial or a piece together summarizing all this. To me, it's very clear. You can put a little table saying, hey, if you wait, even 0 to 4 hours, compared to immediate, your risk is endometritis, chorioamnionitis, mission, and sepsis, and it goes from 3 to 6%, 5 to 10%, and you decide, But at least
I'm thinking, as I guess, because my mind is still full of COVID, where we've just finished a grant developing one of those thousands of infographics on COVID. We just finished a grant doing a infographic with multiple inputs from multiple populations in Canada, BIPOC populations and stuff. So my mind is full of infographics. But what you presented would be a simple, beautiful infographic, graphically presenting. What are we talking about? What are the benefits? What are the risks? You could do it on one page, a one-page infographic, which we could develop, and instead of trying to convene all the professional bodies, just send it to them and get their endorsement, right? And then you could have that in the front cover of the next AJOGMFM, endorsed by. In other words, do the work for them in the form of an infographic. I think it would be because you can see it just the way you graphically showed it. I think this would be a great infographic that we could send around to the different bodies and get endorsed by all the societies. I think it would be very difficult for anybody not to endorse something like this. It is probably the best evidence base there is from all the meta-analysis and the detail. That's what I would suggest, an infographic or one pager that we could send around.
One of the things that I didn't emphasize that I meant to is that these are different databases. And I love it when different people, look at different data and come up with the same exact results. And I think that that's really important. I love it when, you can come up with a new idea, publish it, but then what you really want is people to copy you and hopefully come up with similar results, because if they don't, it don't look so good. And or the vice versa. Sometimes you uncover, stuff that looked, like it was going to save the world, and it really doesn't. And the fact that the data is so consistent, it's wonderful. I'm going to try to wrap it up. We're almost at the top of the hour. I don't know if Nir, you have some last, message or thoughts.
No, I think I kind of mentioned my perspective, my comments. I don't really have anything to add.
Thanks for being with us again, Nir. John.
No more comments. Once again, probably the most entertaining part of my month is the StreamYard thing. So thank you for doing them, Michelle. I think they do more to promote knowledge than all the journals that are published. I think they're excellent. So congratulations, and thank you for inviting me.
It means a lot. Thanks, John. And Federica?
Yes, I'm good. I just want to say, I think that we need to adjust our counseling, and we need to treat the patients as adults, and they can make your own decision after you tell them the real consequences of what they choose. And I'm saying this as a physician, as a woman, as a pregnant patient.
And thanks, Federica. You've been wonderful. And again, thanks for all these wonderful studies. Every time I say an NT, you have infographics in your mind, John. I have, increased NT. And, we show the Nicolaides table, this 95th percentile, more than 3, more than 4, whatever. Here's alive and well. Here's, chromosome abnormalities. Here's structural abnormalities. And people have it right in front of them. And then they make the decision. You're going to have a CVS, terminate, continue, whatever. I would like to see that for everything. And term PROM, it's so easy. You would present the table based on the Lucy Melamed, data, and then they can decide. Well, thanks again, John, Nir, and Federica, and thanks everybody for listening again to another live AJOG FM. Thanks everybody for sending such wonderful research to AJOG FM. Thanks to our Canadian leaders who have published so many amazing, important, practice-changing things, and this is another one. And thanks for all of you doing randomized trials that can change practice. So thanks everyone. Have a great day.
Bye.
Bye-bye.